COIN, Community-Oriented Integration Network, is a network of friends, people of experience, who explore how to develop local communities for health, compassionate communities. My name's Paul, and I was going to introduce to say that what COIN is a network of friends who have experience of and are interested in developing community-oriented integration. And we've at a very important moment, because it seems the ideas that we've been putting forward are being well accepted in very senior places. And we are sort of the second part of this meeting, the last part of this meeting is going to be about thinking through the next steps of the different organisations that are joining in with us in order to try and push that forward while the NHS 10-year plan is still in its sort of 11th hour, to see if what words we can get in there that we can work with after it goes live. Like last month, the aim is not so much to critique the videos themselves, but to ask the questions, in what ways can videos help us to get over the messages of COIN? Because words very often struggle to see the complexity of the things we're talking about, whereas videos and stories are much, much better.
Hello, I am starting a care company. I looked after my mum for 2 years. She had Parkinson's and then finally died of cancer in August. And before that, and I still do, make what my mum used to call very bleak TV documentaries about very serious things. So Ebola, war zones, all sorts of things like that. So that was my job. But I think this afternoon I watched a video with Peter in. Would that be true, Peter?
Which Peter?
Yeah.
Sorry. There's more Peters. Sorry.
Yeah,
the Peter who's not floating on a lake.
I think you did see a video of me. I might as well introduce myself while you've said that. Yeah. I'm Peter. I'm starting to be a med student in September. I was interested in care when I was younger because I was a part of my mum and my grandma's care. And so I decided to get involved in some care aspects with community health workers while I was having some fun in Brazil, basically. And yeah, so that is what the video is basically about. And I hope you enjoy it when you see it.
Well, the video is everything that we want to do and aim to do. So we're inspired by the Buurtzorg model of care in the Netherlands. I'm not sure whether you're aware of it, but what we aim to do is deliver care in small community teams which are self-organising, with an idea that we will deliver care to people in their own homes, and that will be grounded in having one primary carer. It will be bespoke to that person. We will get to know all their informal and formal networks. As part of that, we will also go out into the community. We will become experts in the people we provide care for. So that will be meeting their GP, their district nurse, and also wider spreading the message of our work and this idea of delivering care like a neighbour, like the best neighbour could. So the idea that we call them angels rather than carers, because I hate the word carer and I can't think of a better one, and my mum used to call me her angel, so it's sort of it's nothing religious, but angels, the idea our angels will live 5 or 10 minutes away from the people that they look after, so that they can easily walk to their houses. I live in Chiswick, so our first community group will be in Chiswick.
I want to just admit that Peter is also my son, just in case anyone didn't know that. So I'm very, very proud of him or you, and that's just for the sake of just saying. Let's go around, and Pip, we will come back to that theme both in the last part of this meeting when we discuss the future of COIN, but also next month, June the 26th, I think it is. Connie Jungens is joining us to lead a discussion on the application of the Brazilian Community Health and Wellbeing Worker Initiative in the UK. And a couple of the important things there are that that model doesn't become hijacked and medicalised and remains its community development approach, the like of which you've just described. also that a way of understanding the overall cost savings is embedded, so that it just doesn't add more cost, but is tangibly cost saving. So more.
Well, first, Peter, I didn't recognize you. I think we met once at Paul's house, but I get you and your brother confused. You were the football player, as I remember. Is that right?
The rugby player, I think it was, but I do remember you as well. I do remember you did meet me.
Well, we'll have to have a memory contest here. So I'm Peter Whitehouse. I'm also a movie star. If you go to YouTube, you can see me perform as a geriatric neurologist who talks about alternative ways of caring for people with dementia, the author of The Myth of Alzheimer's. You can see me as a tree doctor, a metaphorical character who asks human beings, what can we learn from trees and forests about health? And behind me is one of my favorite places, the Arboretum outside Cleveland, that I'm very active with. And finally, there is one starring with my grandchildren as a dragon. And that series is going to be expanding. Paul will undoubtedly be worried to hear. I'm a friend of Paul's. I can't remember how long it's been. I'm having memories of walking around the Science Museum and Hyde Park or whatever. And I visited your house a couple of times and haven't heard anything about your mom recently. I hope she's doing well. So give her my greetings.
She was 100 last month.
Sorry?
She was 100 last month.
There you go. Well, I mean, remarkable. So I am a geriatric neurologist, but to finish my introduction, I'm also working on a grant from the NIH with Johns Hopkins to develop a caregiving robot or a companion robot or an assistant robot. So I'm a little eclectic in my interests and a card-carrying Paris-school transdisciplinarian, which also makes me aligned with Paul and his various ideas to transform the world.
I'm a retired psychiatrist and also a fellow of the Faculty of Public Health with a long-standing interest in integrated care. So that's why I'm here.
Hi, I'm Tony. I'm a GP retired from Northwest London, near actually where Paul lives. I am now chair of Age UK London, which campaigns for an age-friendly capital. And that started as a clinical interest and has turned into a campaigning one. I've also had integrated care in various aspects running right through my career. And that's my interest in why I'm here.
I'm not a film star, and nor am I a dragon, although probably look like that now and again. Just a lawyer, a commercial lawyer by background. I spent many years though in health and care with a firm called Capsticks, which specializes in health and care. I now have my own consultancy and do a bit of non-exec work with some healthcare organizations.
Well, hello everyone. My name is Rodrigo Fonseca. I am the biggest fan of Paul Thomas who ever lived, especially because I know that Paul Thomas is not Paul Thomas, but in fact he is Michael Palin. You will discover that. And sometimes he is Ralph Fiennes, but he's an amazing friend and an amazing GP. I work here in Brazil, in Rio de Janeiro. I work with movies, but something else because I'm a researcher, and I work with journalism for television, also for streaming for, well, many places. And my idea, as soon as Paul starts saying me to go, I have some things to share with you about my recent experience on the Cannes Film Festival. Specifically about one point that I think addresses a lot to our discussion on healthcare and healthy at all. I was amazed by the fact that we have many movies on a scary amount about AIDS, about HIV, about the recent growth in the spread of the disease, the virus, the historical background of the virus. It's a subject that's always coming and going from movies and not that much from TV series. But nowadays we have what we would call astonishing wave of that. And I want to share my impressions and some thoughts about it as soon as possible. Thank you, Paul, for the opportunity.
Thank you.
Good evening, all. Lucy Kvapishevich. I've been supporting COIN for probably over 8 years now. Firstly, under Royal College of General Practitioners, where I come across many of people on the call today, and I moved to another organization now, but it's also related to medical profession, so it kind of works nicely. But yeah, I've stayed loyal to COIN, and topics are close to heart, so hopefully I can at least assist with some skills to get us going.
The most indispensable person in COIN, by the way.
Hi. Thank you for letting me join again. I'm Helen Northall from PCC. I got linked into COIN through our chairman, David Colantome, and we are currently supporting ICBs, neighbourhoods, PCNs, etc., to look at the new world of neighbourhood health, supporting ICBs to make sure that they have patients at the centre of commissioning as well. We have a lot of publications, and one of the reasons that David made the link is because he saw the opportunity potentially for us to be able to spread the word of COIN and what you're doing, and get some of the information that you've got out more into the public domain. One of the areas we particularly support, we don't actually badge as PCC. We are a community interest company, and as part of our social mission, we support NHS Networks. NHS Networks is free for anyone working in or interested in health and social care, and it has space for people to network, newsletters to go out that anyone can put appropriate information in, and those go to just under 40,000 people a week. So David sort of linked me into this, and I've had conversations with Paul around how do we spread the word, and potentially in the future, how could we spread the word through some of the work that PCC does as well. We run over 300 events a year for the health and social care sector. So there's opportunities there. I'm not quite sure how to get them all to fruition yet, but I know I have a chat with Paul, with my comms manager, on the call in a week or so, where we can actually start to plan if you want to take that forward at all.
It would come as well. Look, COIN only works with hugely overcommitted people, so it's always the situation that some crucial people can't be there, but that's how it happens. But the intention is to talk about the array of things we got set up for the future in the second part of this meeting, and you're a key part of that. Steve.
Thank you. You realise now I haven't used a microphone on-off switch for quite a long time. I had to relearn it. Fortunately, it's simple enough for me to relearn it in a moment or two. I'm a retired academic general practitioner. I worked for 3 decades in a practice in Kilburn, in northwest London, and for a decade or so at University College London as an academic. And I'm in the process of writing the history of the practice I worked in.
So Steve very, very modestly left out his credentials as being one of the great movers and shakers in general practice in the last 40 years. So everyone knows, of any age, knows Steve. Are we done? It does seem to me that we are in another one of those places of transition. COIN is a very organic thing. It came out of the London Journal of Primary Care in 2018 after 10 years of that. And before then, there was going right back to the 1980s, was the Association of General Practice in Urban Deprived Areas, all thinking through the complexity and the theory of how one makes complex worlds work with a humanistic, ecological understanding of health. So we could well be at we think we are at a new transitional stage. They happen, you only really recognize transitions with hindsight, but it feels to me that we're in another one of those places that happens every so often. And we'll be discussing that in the second part of the meeting.
Born in a favela here in Rio de Janeiro, a very poor area in the north of Rio, called Complexo do Alemão. The translation would literally be the German complex. It's the name of the place, because when the railroads were created around here in the 19th century, there was a German invasion with them, so that place was called German complex. It was a place that was absolutely destroyed by violence, not only by drug dealers and the fight with the police, but it nowadays is suffering with the attack of something we in Portuguese call milícias, what would be a Portuguese variation for mafia, but a mafia that's not the typical Corleone mafia from the movies, or Brian De Palma Scarface mob, but a group of policemen that runs parallel activities, asking and demanding for other people's money with violent approach, using their guns, using all kinds of threats. I was there because I have an 5-year-old mother who I take care of her with my brother. I have an older brother. He is the main carer, but I have to support her with money and with many things. So I have to go there from time to time.
Yeah. Welcome to James Kingsland and Laura Calamos, who just arrived now from whichever countries you're in at the moment. We're going to move at this moment straight on to look at Rodrigo's film, which he filmed in one of the favelas of Rio. After that, we're going to show Laura Donnelly's video of the community health workers in Brazil, and then Peter's video of a gap year student investigating these things.
This is a traditional landscape of a Brazilian suburb. I'm calling from a place called Complexo do Alemão. My name is Rodrigo Fonseca. As you may know, I work with cinema. I am a big friend of Paul Thomas, and I'm a big fan of the COI. And I have to tell you something. Recently, I came back from Cannes Film Festival, the internationally most acclaimed movie marathon or film marathon in the world, in France, in the Côte d'Azur. And basically, one of the main themes over there was the AIDS, how the virus keeps spreading, how the virus became killing machine during the early 80s, and how it was used as a tool to exterminate population, especially gay population, poor population, uninformed population. The subject of AIDS came back in form of a very prestigious mini-series, Oxygen Mask Won't Fall Soon. It's an HBO Now Max streaming series that will be released in 2 or 3 months. There is a movie, very interesting French movie called Alpha, where there is a metaphor for AIDS called the red wind or the crimson wind. And there was a very powerful Chilean movie called The Mysterious Sight of the Flamingo, La Misteriosa Mirada del Flamengo, where transvestites on a kind of bordello in a mining zone of Chile in the outskirts of Santiago start to receive people that became infected by the virus. I think there is a theme going on right now with a huge discussion about the topic. In Brazil, there is a very prestigious doctor named Marcia Rashid. She's from Lebanese heritage. She's a doctor. She is an infectologist. She's writing books on it, and she keeps informing motion pictures and TV series about the cases. So I think some names, some tendencies for which you keep an eye on.
It would have been interesting, Paul, to see more of the favela, actually. Just very interesting to kind of capture, to see some of, as Rodrigo said, the local background. Yeah, and maybe interesting in the future to see a little bit more of that. And yeah.
I must say, I thought the same thing, because I think when I was there, in a slightly different favela, there was the teenagers with long guns in the street corners managing things.
Chris and Paul, just for you to know, that was my initial idea,
Mhm.
but there was a bunch of armed guys that were forbidden me to shoot, although I'm
Okay.
alone.
Yeah.
So
Yeah.
that was the only point I could shoot. And I had to, since they know me, because my mother lives there, my brother works there, okay. But in the other way around, they would take my phone from me.
Yes.
So I did what's possible. But Chris, I think you may have some curiosity. I will give a very brief explanation to everyone. Each favela in Rio de Janeiro is different due to the local landscape. The place where I shot, it's far from the sea. We have no beaches around. It's something like a 30-minute bus ride until the seashore where you have the harbor. So it's a mountain area. So the drug dealers, all the drug stuff, and the more conventional favela geography with small houses, mud-made houses, they are in those mountains. I was in what we call here the asphalt. So asphalt is the metaphor we say to a nearby area, but where you are not in a vertical position when you are in a favela. So at that place I was safe, especially because there was a road in front of me. It was the only possible way to shoot. Paul, you went that place when you went to see my mother.
Wanted to comment on something that I liked in video, Rodrigo, that you made, how nicely you linked into something massive, which is Cannes Movie Festival, that brought one particular topic, obviously, in this year. And I reckon, there are different themes that occur year on year that you've picked up on, and obviously trying to bring, I guess, to us in the form of that movie. And you've linked to the area that obviously must be struggling with it or struggled back in days. So it's like you said, it's just those minor things that, if you made a longer shoot or screened into the wrong corner, you would have landed in trouble, which obviously it's not the point of that, but it's just bringing something that's already been talked about on like international scene into, kind of local community and simply shooting it. Yeah, I've really liked that.
There are two reasons. First reason, the international one. I went to Cannes Film Festival with a COI meeting eye, so I was looking for film things for you guys. But it was it wasn't unnecessary to keep that alarm, that coin alarm on, because Khan gave it the answer to me in the beginning. Because we went there, we were sure we would listen to stories about Ukraine and Palestine, of course, for obvious reason. The Palme d'Or winner is an Iranian movie shot by a director who was censored, Jafar Panahi. But The amount of movies about AIDS really surprised. Cannes has 300 movies, 300 movies, 30 movies, 30 we're talking about AIDS. That's huge. That's not common. Usually we have one or two at if possible. And I saw some films about AIDS in Berlin in February as well. The reason why I shot the movie at my place is not only because of anthropological reason. There is another reason, and you understand. You were so kind to analyze the link I tried to present. There is a hospital in the backyard, in my back. It's called Bom Sucesso. It's Bom Sucesso is the name of the place. Bom Sucesso's General Hospital. It's one of the biggest hospitals in Latin America. And it was the first hospital in Rio de Janeiro that during the 80s needed to be shut off, to be evacuated, because the first cases of AIDS were there. The hospital has not the capacity to deal with that. At that time, they use it to call AIDS the plague. So I don't think it's a random coincidence. I think there is something about it. So
there's something to my eyes then about get the feel of the local place. Explaining the constraints of the video and also linking with the bigger picture and other international things that is more magical than just hearing about it.
Thank you, Rodrigo, for that. And can I ask you a question about safety? Is that a useful way to think about your experience of making that film in that place on that day? That you had some license to do that because of your connections with the area, and therefore safety becomes one of those things that we need to factor in to think about working in communities. Or am I overinterpreting it?
Just for you to know, I did the movie today, some 1 hour before our meeting. I had a previous video, but it was shot before Cannes. I thought I had to restart and to do something new. So I decided to do something today. I went there to shoot for you guys, but there was a prohibition. It's not safe. There are guys passing over me, like hovering over me with their motorcycles all the time. They are armed, but they know me, so it was safe.
Safe-ish, yeah.
Yeah, it was safe. Yeah. But I wouldn't recommend anyone to do that.
Thank you very much. And one issue that's coming out here, it strikes me, is access. If it's too dangerous for you to be there, then you can't be there. This is a 2 or 3 minute video made by Laura Donnelly, who is the health editor for the Telegraph newspaper, which has a circulation of, I think, 600,000 a day. Now, I have to acknowledge that all of the videos here was made through Rodrigo. She's talking about Brazil, but the links and the connections and the photographer of the video actually were found by Rodrigo, even though I don't think Laura acknowledges that. I want to point out here that although I had a long chat with her before she did this, saying that the danger is that the Brazilian community health and well-being workers would become institutionalized and medicalized, and therefore they will change from being community developers who deal with the real issues to be medicalized to do things like blood pressure and diabetes control and things like that. And I just draw to your attention that how you shoot a video matters quite a lot, because you can get over lots of subtleties. So notice how she's chosen to choose the bits of the people in the white coats and standing over people with a clipboard, ticking boxes and so on, which of course does suit the Telegraph readership. But actually, that's only her. And she's a very nice woman who you can see some of this is a very well written article. But actually, it's choosing to show aspects of the community health workers that are not the whole story, or even the big COIN story. Stop there, Paul, and press go, please.
Health officials are looking closely at models from other countries, most notably in Brazil, where an army of community health workers goes door to door, checking on people. So I've come to Rio to see the scheme in action and to find out if it's really making a difference.
E o remédio, já tá tomando?
Tô tomando, tô.
Tá?
Agora com esse calor, tô um pouco sufocada, né? De ficar...
É de suma importância pra gente, porque sem eles a gente não consegue trabalhar. Eles que moram dentro da comunidade, assim, e aí eles conhecem a comunidade mais que a gente.
Advocates of the door knocking scheme say it can work anywhere, including in the most remote areas. So I've come to Manaus, in the Amazon, to see the scheme at work in the jungle.
Façam as visitas deles, todos os dias eles fazem visitas domiciliares, vão para as casas, visitam, o que eles veem assim que precisa de uma consulta médica.
O que seria de uma unidade de saúde se limitando somente aos atendimentos médicos? Iria ter que vir até a unidade. E o ACS, ele faz essa ponte, né, com a família, sabendo das suas necessidades, traz até nós.
Como é que a senhora tem se sentido ultimamente? Tá bem? Tá tomando os remedinhos direitinho? Aqui, ó. Enquanto eu vou fazer aqui o seu cadastro individual, eu vou pedir pro meu técnico vir aqui fazer a sua aferição da sua pressão, tá? Tem hipertensão? Sim, né? Como é que tá a mobilidade dela?
Ela não anda.
Ela não anda, né? Sim, o médico já passou fisioterapia para ela. Eu voltarei aqui periodicamente para fazer a visita junto à senhora, tá, dona Esther?
The home visits also include checking the surrounding environment for health risks.
É para você identificar focos de mosquitos Aedes aegypti, que no momento chuvoso em todo o nosso país está acontecendo muitos casos de Aedes aegypti, tá, ou seja, a dengue, tá, o índice está muito alto e é necessário fazer esse controle epidemiológico.
Ele tem um olhar macro de toda a situação dentro daquela família, se está oferecendo algum risco de saúde, né? Então isso aí se chama prevenção e promoção à saúde.
When there is an emergency, the ambulance service, delivered by boat, works with the agents to ensure that the right care is given.
Geralmente o agente comunitário está lá na comunidade e eles passam o paciente para a gente. Na ocorrência que eu fiz passada, o agente comunitário pegou num papel e escreveu tudo que ele tinha. Ele fez o primeiro atendimento do paciente e entregou para mim, para a nossa equipe dentro da lancha.
É um modelo que ele te dá acesso, tem a porta aberta, o acesso, né, até nós da saúde. Então, nenhum indivíduo ele fica privado de saúde através desse modelo que é o SUS, né? Sistema Único de Saúde, ele já fala, né, que é um sistema que deu certo aqui no Brasil.
Now, the question for Wes Streeting. Is this a model that could help save the NHS?
Because everybody talks about Brazilian problems and controversial facts, but we never had a possibility to reflect about it. And you need to think about something. The country just came out strong political turmoil after the coup d'etat of 2016 and after the Bolsonaro government that changed everything because it made the right wing even more powerful than it was before.
So my name is Laura Calamos. I'm a clinical assistant professor at the University of Michigan in Ann Arbor, and I'm a nurse and family nurse practitioner trained in community-oriented primary care. What I think is interesting in the video is the idea that this is reporting, and I think Rodrigo said this as well a little bit, that how you take a video, what your viewpoint is, comes through in your style of reporting as you're talking about what you experience. And there was a study done at King's when I was there where they were trying to figure out how to fix, how to rebuild a new hospital. And so they went to the pediatric ward and they gave children GoPros and they put them on their head and they had them go to the current children's ward and walk around. And it just struck me how in watching my colleagues study that the perspective of a child of an adult space that's supposed to be for them, they hit a lot of walls. The counters were too high, the chairs were too big, everything, you know, to see it through their eyes is always a challenge. So when a reporter from somewhere else comes to a place and reports about something, it's always going to objectify it a little bit. And it's natural in reporting to say, let's only do 3 minutes and see if we can get a point across, a thesis across, try to make a point. But what does it look like when you put the camera in the eyes of the person who's experiencing it and let them talk? There's always these interesting community projects where they give the kids the cameras, they give the teenagers the cameras, they give the local population the cameras, and then they let them film it from their point of view. So it's just a long-winded way of saying, from a COIN perspective of the content of the tool of a 3-minute video, what is it like for somebody local to take over the lens and let it speak for them? What we heard from Rodrigo is because of safety issues, he couldn't actually film what he wanted to film. And that's the message. That was a really important piece for me. I'm interested in everything he experienced in cons and everything else, but the fact that I can't show you what I want to show you stood out loud and clear. Just something to think about: who's got the camera, who's got the lens, whose perspective it is, and what does that 3-minute allow us to do?
Yes, the more general point of the use of short videos, I actually have invested in a new camera myself and microphones because I think short videos are a very powerful way to have an impact. And the link I put into the chat was something which is kind of an FYI for everybody in COIN, because it's another UK-US collaboration that I'm involved in now called Concilium Scientific, which does a whole series of programming on the influence of the pharmaceutical industry on healthcare in the world, in both countries. So that's a sidebar. But they've just launched a series of short videos, which is what I made the link to. And I guess the other last thing, and these are rather divergent, is I am well aware, because I actually attended a conference in Belém, that COP30 is going to be in Brazil. And a lot of the community health issues that were featured in that film, dengue and so on, are going to be intensified by climate change. So I just wondered whether you have any thoughts about how that meeting is going to be covered, COP30, the Conference on Parties about Climate Change.
That I came tonight not expecting to be able to contribute, but actually we're right in my wheelhouse. So yeah, as somebody who makes documentaries all the time, to Laura's point, normally, Laura, what you get is what whoever is being giving the money. So in this case, the Telegraph is paying, so you know, that's what you get. I'm assuming that the main point of these films is how we can communicate community care to people. And I think I think films are an amazing way of doing that. I think it can be more abstract than the things we're looking at. I think it could be, it doesn't necessarily have to be somebody talking to it. It could be sync sound laid over beautiful shots of nature, as Peter was saying, you know, nature and gardens and all these wonderful things give you a sense of that care and calm and those things that are maybe important to the people that we're talking about. And I also think human stories, you know, like yours, Paul, like talking to you, hearing about how you cared for your wife and your mum, talking to people that are experiencing that care, capturing those community and relationship moments are really special. And by seeing those or hearing those gives you 1,000 words, and it connects to everybody's heart. They instantly understand what you're talking about. The obvious becomes obvious.
Yeah, I just wanted to reinforce what Philip has just said, and it relates back to your point at the beginning, Paul, of the use of videos, stories, and the arts in general, that I think these are extremely effective. And I think the reason they're effective is because they engage people at an emotional level, not just at an intellectual level. And I think if you're going to try to convince people, you have to engage them at a feeling level. It can't be just too all cerebral.
Yeah, James Kingsland. I get to the stage where I feel like saying, do you know who I was? Currently a clinical professor in the School of Medicine at the recently renamed School University of Lancashire. I'm also a visiting professor at Janaki Medical College in Tribhuvan University in Nepal, and various other things. But I was the colleague who said, you know, for West Streeting, will this model save the NHS? No, absolutely not. Albeit a great model. I first heard about it maybe 6-7 years ago. We love to adopt things without fully understanding it. So Rodrigo's video was really helpful, but it's a model that I'm oversimplifying, but improving access, and there's always the access to what, and as a result of improving access, and we're talking about access for people who are marginalised, vulnerable, hardly reached, probably with poor health literacy, which we have a great issue in the UK with as well. But dealing with that is going to increase demand on the system. And why I'm saying this won't help, as a long-term and a slow progressive social change, a great way to start. But is it going to solve the NHS? Because in a year's time, if West Streeting is going to say we've saved the NHS, it's going to be we've reduced hospital admissions, we've reduced readmissions, we've saved length of stay in beds. It's all going to be focused on have we solved the hospital waiting crisis and access to healthcare. So sadly, the Brazil model will not save the NHS. As a long-term social movement to change how we reach people who do not access care, who are vulnerable or marginalised, absolutely. But I think trying to link that approach to a model to save the NHS, there's a whole range of other things. For example, the payment system for the NHS would have to change dramatically so that we could focus on those in greater need who are hardly reached, rather than what we're trying to do at the moment, just get orthopaedic waiting lists down.
My name is Peter again. The reason I got into this kind of subject is because I was into the role of carers when I was a part of the care of my grandma and my mum. When I went into my gap year, I decided to go to Brazil. And when I went to Brazil, I had some goals in mind. I wanted to learn Portuguese, learn the culture. But I also didn't want to abandon the idea that I was going to do medicine this September. By the way, I'm going to be a student in September. But yeah, and I decided that I need to learn it in some way. It was going to be a small idea at first, but it kind of just ended up becoming better and better because loads of people started becoming a part of it and helped me out with it. And while I was also just going to keep it as a written format, I decided that maybe speaking it would be a better way to express and show some pictures that were, you know, a part of my journey. Yeah, I think, what I was going to say, I think as someone who's young, and I've seen a lot of videos where it's just straight face speaking to the camera rather than documentary style, one of the things I tried to I'd say focus on was lighting. and like audio. I feel like those are the kind of things that get people's attention at first. And I think that's something that could, help this kind of project. Also, James, I just wanted to mention, I obviously I'm way less experienced than every single one of you. And I can agree that I don't think community health workers will be the saving of the NHS. But I think that through some of the things that a lot of people have shown and seen, it's definitely something that could help certain parts of the NHS that you mentioned and that aren't even mentioned, like behind the scenes kind of things. But again, I'm not even a medical student yet, so I don't even know that kind of stuff yet. Anyway, please see the video now.
Hello, my name is Peter. I became interested in the role of carers because I was a part of the care of my mum and grandma. 1 in 10 of the English population is a carer, and in some groups it's as large as 1 in 5. This is mainly because of the increasing number of elderly people. But unpaid informal UK carers provide the equivalent of £184 billion yearly. That's the equivalent of the entire NHS and social care budget. But despite this, SALT data shows that 70% of carers were given insufficient support. My interest in caring came at the same time as my interest in Brazil's music and culture, which led me to plan to spend most of my time in Brazil during my gap year. This led me down a rabbit hole where I ended up reading a paper by Matthew Harris on integrating public and primary healthcare through community health workers, also known as agentes comunitários de saúde. In the Brazilian model, community health workers are local people who work in groups of 4 to 6 in a health unit with a GP, a nurse, and a nurse auxiliary. Each community health worker is assigned 150 households where each household receives at least 1 visit a month. They look for community and household determinants for individuals and the population's health. They can then develop public action to deal with common issues, as well as get more up-to-date data of the population. And in these visits, they give the community a voice that can be heard in the clinic. Community health workers have a variety of roles in clinical care, such as chronic disease management and triage, in public health, like data collection, and in community empowerment, like education groups. After speaking to Matthew Harris, he kindly introduced me to Connie Jungens, the doctor who got the community health worker model off the ground in London. Luckily for me, she then introduced me to her community health workers. I interviewed them about their work, and I quickly realized that some of their actions went way beyond the job description, like one community health worker who helped a young carer go through the university application process. Those community health workers set up a coffee meeting in the morning where the community could come together and meet. There, 2 mums who were both struggling with autistic children met each other. The coffee meetings allowed them to find each other, and they have supported each other since. Arguably, this kind of support is better than any kind of support a healthcare service can provide, because it not only provides short-term support, it allows the community to come together and form bonds for long-term support. The community is strengthened and the carers feel seen. Luckily for me, Connie Jungens was planning to go to Brazil to see community health workers while I was there. She invited me to a Theo Cruz talk where her and other doctors spoke. After speaking a bit further, we planned to meet in Manaus in the Amazonas, where I also met doctors Alessandro Jatoba and Paulo Rodrigues. There we went around and saw medics who work in the ambulance boat service and also community health workers who work in a GP practice. While my Portuguese wasn't perfect at this point, I understood quickly that some of the places the community health workers have to go to are really dangerous. Many of them have been shot at and many of them have been threatened regularly. But despite this, they work well within the community. Similarly, while speaking to the ambulance boat service, they showed us the journey they make to reach certain communities. Some of the journeys are up to 14 hours depending on the conditions. On top of this, they're at risk of the boat being damaged by large pieces of wood floating from the Amazon rainforest. The waves can be intense and, as it's the rainforest, it can rain a lot. After seeing both teams, I realised how resilient and community-minded the healthcare workers are. Either their attitude came before the model or developed through the model. But either way, they were extremely happy to go the extra mile because they saw how it affected the community. In my opinion, community health workers in the UK could be a valuable resource for carers. Currently, carers can receive help from various sources, like palliative care nurses, district nurses, or a GP, who may or may not be communicating with each other. Community health workers could help provide a more rounded care,
by allowing the carers to understand the system better and insisting on things such as home-based records, continuity of care, and caring for the whole household instead of just the sick person. In 2024, a study was conducted on the barriers and facilitators to the integration of community health workers in the Bronx. Community health workers reported that accompanying clinicians on patient visits led to greater patient acceptance of referrals, while program staff reported that there was a power dynamic between community health workers and the clinicians that led to the community health workers to find it difficult to advocate for themselves at times. These are challenges that are expected to be seen when implementing a new system that I believe the UK can overcome. Community health workers could support carers and improve team working in the NHS, and so reduce overall costs and improve quality of care and social cohesion. While this may sound difficult, what I saw in Brazil is proof that it is possible. Thank you very much.
Thank you very much.
So
I'm just applauding.
Oh, sorry. Sanjeev might have been here. Sanjeev Ahluwalia is reforming the medical school curriculum for Anglia Ruskin University. Is another COIN initiative that we're supporting. Can I ask you, generally speaking here, is this a helpful thing for gap year students to do before doing medicine? I mean, I could imagine a university saying, we would encourage people to have gap years and to be mentored to go into places where they experience things far away from what they're going to get in the medical school. And
it was incredible. Peter's just done amazing, incredible things in a relatively short period of time. Never mind, sort of sounds like learning Portuguese. So, but yeah, and I don't think we should see it as, everybody talks about solving the NHS, but I think what Peter's talking about and what we saw from the earlier films was, the sort of thing that isn't happening, in the UK, and it is impacting on prevention and, keeping people out of hospitals. And there are some fantastic ideas there. And, one would expect the commissioners and the integrated care boards to be picking up on this stuff because it's, there's a new approach, and a lot of the papers, even including on neighborhoods, sort of recently sort of slightly churn out the same sort of things that were coming out 10 years ago. And I think the things that Peter's seeing, and talking about, and Rodrigo, and in the Telegraph, are sort of, real practical things that, I think could make a change. So, a brilliant film, Peter.
Wanted to thank you, Peter. I think your video is amazing, and yes, I think I would encourage students to do this during a gap year. And I think there's a lot of different ways that community experiences open up your world, whether or not you have good references, which I'm sure they're fine. The career that you're about to embark on will be adjusted every step of the way by the people you meet, and your curiosity is such a powerful tool that it just comes through your experiences and making all those connections between your system at home and what you experienced in Brazil. So brilliant. Thank you for that. Short story. After my undergraduate year, I went to Nepal, and I was in the Himalayas, and I met a young woman who was weighing babies in fruit baskets up in the Himalayas. And I thought, what am I studying old books for? I should probably go to healthcare. I was completely entranced at the age of 19. I went back to Nepal 30 something years later. Okay, 40 years, let's be honest. I was back there in November. In November, I had the opportunity to visit Patton Hospital in Kathmandu. And I told them the story. I met this young woman. She was doing community health. She was a health nurse. It changed my world. I completely changed my major. I completely changed my whole career. And they said, oh, let's introduce you to the community health program. And they walked me through this hospital, and there was a community health program over the door. She was a student nurse in the first class of that community-oriented program, where they sent students out into the villages to start to do primary care up in the hills. And that program exists today. And one of the physicians is actually using an app to take medical students and visit pregnant women up in the mountain towns to experience community care, not just to learn how to do maternity care, not just to learn how to be a doctor, but to learn how communities work. And so you're an extension of all these kinds of programs that have touched all of our lives, and are still going. And so thank you for giving me hope that there are still people who want to go forward in the future to touch people where they live.
Story. I think that's a great example, proving to the fact that a lot of people would love to show their story when given the chance. And I think that these videos would be a good way to show that, perhaps.
Best of luck to you.
What we stand for on the pieces of paper that we've submitted to Wes Streeting and the NHS consultation process seem to be being well received by people in senior places. So we are aiming to persuade the RCGP to support the things that we're doing, and the carers within neighbourhoods to be supported also, to form an alliance of generalists. So that's on its way, and you've heard a bit of that in the past, and there's more to come. The idea is that we will continue the COIN approach of holding monthly meetings of an hour and a half where this kind of thing gets presented, that is not just advertising things, but looking forward. That will then become the video that we put on the YouTube channel, the blog that will go on to Health Matters, which Steve Iliff runs. Some will go on to papers into the Journal of Holistic Healthcare run by David Peters, that we've got a sort of a section with. Others will go on to places like the British Journal of General Practice. We also have very good links. And then our allies, including James and his 65 primary care networks that he supports, will hopefully be able to do the kind of videos that we're talking about to illustrate these things, both as training materials and to develop communities in whatever places they were developing communities. And in a way, this is meant to be almost like an antidote to the pharmaceutical type videos that are arguing the value of obesity losing drugs and so on.
Very happy for you to come to me. As I said in my introduction, it's very much PCC, which is a community interest company, just making an open offer to help to communicate what COIN is doing. And we could do that in a neutral way through pushing information out through publications, including NHS networks. And it's not about us necessarily needing to host stuff. All the sources that you have just mentioned, we would much prefer to link to what's on those and say what information is where, not host it ourselves. Selfishly, hosting things takes up server space, so we would much rather link to others. But it's about, if you wanted a repository and a way of communicating through our newsletters that this is here and encouraging people to look, that offer is very much open to you. We're not doing a lot on communities ourselves at the moment. Our focus is very, very much on commissioning primary care, supporting people to develop neighbourhood working. But I have worked a number of times with patients, with the public, with local communities, and unfortunately, like James, I don't think this is going to solve the NHS crisis that we're currently in, but I think it's a really good step forward to be able to communicate out what is possible, capture experience, and help people to understand through patients, carers, community eyes, what the services could do and how things could work if they were supported.
Just on the programme and how it might link the programme I'm running at the moment, we're about to start a summative report across these 65 sites with semi-structured interviews about producing a playbook, how to deliver or address issues of people living with complex lives and having unfair outcomes to health. We've also got a research bid starting to look at communities, issues, unknown unknowns. There's not even explicit or tacit knowledge that mobilises certain communities or people who are living in communities where there's high vulnerability, marginalised, not accessing. Are there issues we don't know about?